This is Dr. J. Randall Curtis at the University of Washington, Seattle, and you are speaking here about how there's a collaboration of these different critical care societies to devise performance measures. And your particular component of this talk is reimbursement and how that's in the future going to tie into how doctors are paid based on their performance potentially. And I just want to know sort of what your take-home messages are.
Yeah, well, I think that pay for performance, as it's called, or P4P, is coming. In fact, it's already here. That we have a long tradition of paying physicians for the quantity of work that they do, and it's gotten us into a bit of a tough spot with medicine in the U.S. in terms of it taking up an enormous amount of our gross domestic product, and yet not producing better quality than some other nations that spend a lot less. So I think the idea of paying for quality rather than quantity makes a lot of sense.
So is it the instance, I've heard this other specialties, where we're going to try to devise our own performance measures before it's done for us?
Exactly. I think that's exactly right. I think that although it makes a lot of sense to do this in principle, the rub is with how you do it. The devil's in the details. And in critical care, I think, has a number of unique features that make it particularly difficult. Our patients are much sicker. They have many diseases going on at the same time. They're cared for by a multidisciplinary team, not an individual physician. So for a lot of reasons, I think critical care is going to be an area where it's difficult to implement these effectively. And I think physicians and professional societies need to be involved in developing them and testing them.
As one of the challenges, the fact that you have surgeons involved and internists involved and interventionists involved and all these different specialties, and how you work out who gets reimbursed for what.
Exactly, and all of these people are working together as a team, and as well as nurses and respiratory therapists and social workers, all working together as a team, and we need to find ways to reward the team, because the care is delivered by teams.
If I was an emergency physician, or if I was a surgeon, or someone involved in critical care, or like yourself, an internist, what can I do now to sort of kind of have the deck in my favor, so to speak, in terms of reimbursement and payment? Is there something they can do now?
Yeah, my sense is that the hospitals and the physicians who are participating in the voluntary programs now, figuring out how to collect the data, figuring out how to make changes, implement changes that will actually make the data look better, reduce hospital-acquired infections, and things like that, are gonna have a leg up. They're going to be the ones who are performing the best on the measures that we know are going to be used, and they're also going to be the ones that have the systems in place to figure out how to make changes that will improve performance.
This is Damian McNamara with Global Medical News Network.